said before, even if we are a little bit far away from aging and therapies and the classical context that you have in your webinar series, uveal melanoma, which I will show a little bit later, is something that affects the last third of the typical lifespan of a human being. So let's see. Okay, you said this, biography, whatever. I'm just gonna go directly to the overview of my presentation. We're gonna talk a little bit about the introductory content I'm gonna show you. We're gonna dive deeper to uveal melanoma disease specifically. Then we're gonna see a potential research strategy, how to meet this critical need. And I will give all the arguments about everything that I say. And we're going to finish with a little bit of entrepreneurship in the context of biotech and how we go from maybe research strategy to entrepreneurship and what are the challenges that we can have. So I knew this is what this slide was going to be totally basic for you guys because you're medical doctors. But what I want to remind you is that the eye consists of 3 layers. The outer one, which is the fibrous corneous scleral layer, the intermediate one, which is the uvea or uveal tract. And I want you to keep these 3 names in your head: iris, ciliary body, and choroid. And the internal, which is the neural layer of retina. So melanocytes, this is a graphical illustration of melanocytes, that they're actually the pigment-producing cells. They inhabit this intermediate layer, the uveal tract. And as you can see here, as you can see in this quick review, let's say summary of the interaction, tyrosinase, the enzyme, catalyzes the transformation of tyrosine to dopaquinone, and then through other reactions and depending on the environment, we have the production of F-melanin or pheomelanin, generally melanin, which protects the skin from UV radiation. There are many anatomical locations that we can find melanocytes. So, for example, we have the skin in the outer layer, which is the epidermis, or like we said before, in the uveal tract of the eye. But unfortunately, like other cell types in our body, sometimes they behave a little bit abnormal, and therefore they give rise to melanoma tumors, such as the skin one, also known as cutaneous melanoma, or the one originated from the uveal tract, which is called uveal melanoma. And this was the main subject of my PhD research. These 2 entities are completely different, although they are melanomas. They are completely different in terms of genetics, because, for example, we have BRAF and NRAS mutations in the cutaneous melanoma that are either super rare or completely absent of the uveal melanoma landscape. They're different in terms of physiology, and I'll explain later these 3 subcategories here. They're different in terms of metastases. And the most important thing is that they are different in terms of therapy. So we have seen the last few years significant improvement in the patient's outcome for the targeted therapies or immunotherapies. However, uveal melanoma is still highly unresponsive to all types of therapies, even to the ones that they have shown a benefit for cutaneous melanoma. So let's go to uveal melanoma key statistics, because in the beginning, my title writes that it's a rare disease. It's the most primary intraocular malignancy in the adult population. However, it consists 3 to 5% of total melanomas, as it is shown in this pie chart. And we count approximately worldwide, USA and Europe, from 5 to 7 patients per million per year. Another additional information I would like to give for the geographical, let's say, criteria is that when we go from southern latitude to northern latitude, we have a higher rate of uveal melanoma, giving us a hint that maybe UV radiation is not the main factor for this disease. And speaking of risk factors, actually they have shown in some research work that it is the light-colored eyes and fair skin. However, which is bizarre, not the light-colored hair. It's the old age. It's the observation of dysplastic uveal nevus congenital ocular melanocytosis, BAP1 predisposition syndrome, that we can see it also in other cancers, Observation of Xeroderma pigmentosum, it's a low association so far. Family predisposition, which is rarely characterized. And there has been found a UV signature, an association with iris melanomas without meaning that this is the only and primary factor for iris melanoma. But someone could ask me, why study this cancer? Why study a rare cancer? So I have three arguments usually. One is based on the humanitarian, let's say, aspect and the higher cause behind the research is that every patient is a patient. Regardless if it has a rare disease or if it's a common disease, you name it. So every patient deserves to have a better quality of life, prolongation in the survival, etc. The other two arguments derive from statistics, which, like I said before, the mean age of diagnosis is 60 years, with a peak at 65. And according to the National Center of Health Statistics, or the Eurostat of Europe, you can see that we have a mean life expectancy of around 80 years in both regions. And so it affects the last third of a standard lifespan of an adult. Last argument is that 50% of the patients with primary disease, they develop metastasis primarily in the liver. And so they die within a year. It doesn't work. Too bad. I had an animation here. Okay. Is it stuck? Oops. Excuse me, something happened. Yeah, and like what I was saying, yeah, that they develop metastasis primarily in the liver, and 80 to 9% of the patients, they die within a year. So it's very fast. Like I said before, I'm gonna show what are these three categories. So primary uveal melanoma is divided according to the sub-anatomical location. So we have 90%, so the majority of the primary uveal melanomas derives from choroid. And then the remaining 10% is divided between ciliary body and iris melanoma. The tumor mutational burden of uveal melanoma is very low compared to other cancers. And we have seen that the main molecular drivers are GNAQ and GNA11 in the majority of the patients, and they're activating somatic mutations, followed by cis-LTR2, another type of gene for a receptor, and PLCB4 and PLCB3, its homolog. These mutations are mutually exclusive. That means rarely, or actually almost never, we don't see them happening together at the same time in an individual or in a tumor. Unfortunately, we have disease progression, and for this, we have unfortunately, we require a second set of molecular alterations with a focal point on BAP1 loss, followed by translation initiation factor and splicing factors, which are also mutually exclusive, so we cannot have them at the same time in the same tumor or individual. And they're also strongly predictive for uveal melanoma metastases. So tumor classification of uveal melanoma is based on molecular and cytogenetic criteria, mainly involving chromosome 3 status and BAP1 loss. So for example, in this table, if we had an imaginary patient with monosomy 3 and BAP1 loss, we would automatically categorize him as high metastatic risk, while the opposite if there was disomy 3 or AIF1AX mutation or SF3B1 as a low metastatic risk, excuse me. Harbour et al., as you can see here, and his research team that they're active in US currently, they have made, let's say, they have added an additional layer of stratification of patients according to the PRAME expression, which is the preferentially expressed antigen in melanoma. And so they have found that inside the cluster of low metastases, when you have high expression of PRAME, you're automatically categorized to a higher level of metastases. This has been extrapolated for the class 2, for the cluster of high metastatic risk with the same criteria. So they have also developed this prognostic tool that they're using, the medical doctors in clinics, DecisionTx Uveal Melanoma, and it's available by Castle Biosciences. And they stratify the patients to 3 categories, as you see here, according to a 15-gene signature analysis. And this panel can be complemented by PRAME expression or other markers here in order to predict the metastatic risk of a patient. So we move from the genetics now to the uveal melanoma signaling. So it's a little bit of biology here. I'm going to try to make it as simple as possible. This blue line depicts the cellular membrane. Outside, we have the extracellular fluid, so we are outside of the cell here. And the other part refers to the cytoplasm, so we are inside the cell. What happens for the molecular landscape of uveal melanoma is that we have seen that we have mutations at the JNAQ and GNA11 primarily. They affect corresponding kinases and their pathways, such as the MAPK pathway, which is involved in cell proliferation, the PI3K-AKT pathway for cell growth and survival, the ROGDPA signaling, cytoskeleton remodeling and cell growth, and recently, the ARF6 that acts as a proximal node for GNAQ signaling. Although, to my knowledge, and so far from the publications, there is no ARF6 mutations in uveal melanoma. Recently, there has been another pathway that has emerged, has been highlighted. It's the LKB1-SIG2 pathway, which is involved in the cell proliferation. And like I said, a wonderful research work from the lab that I was in have shown the implication with really amazing experiments of LKB1-SIG2 in the metastatic uveal melanoma cell proliferation. Oh, excuse me. There are inhibitors because naturally someone could say, okay, these are the main pathways in uveal melanoma, so let's try to inhibit them in order to have some sort of benefit, survival benefit, you name it. So there have been inhibitors such as trametinib, defactinib, everolimus, etc., that they're targeting these pathways in order to block them. They have shown an efficacy in vitro. However, when they go to clinics, this doesn't reflect the reality with our patients. And speaking of therapies, for primary uveal melanoma, just to remind you that 90% is choroidal melanoma, we have 2 approaches, which is radiotherapy and surgical approach. For radiotherapy, there is black brachytherapy, charged particle radiotherapy, or also known proton beam radiotherapy. And for the surgical approach, we have either local resection of the tumor or complete enucleation of the eye. There is a tendency the last 15 years, 10 to 15 years, that medical doctors are trying to have a more glow-preserving approach, meaning to keep the eye for all the good reasons, and try to avoid enucleation. Despite the favorable outcome from the local tumor control from the primary uveal melanoma, like we said in previous slides, 50% of patients develop metastases, and currently there is no standard treatment for this metastatic disease. And we have many clinical trials that they're running currently. So I'm going to show you 3 slides. We're not going to go through each therapy that's under clinical trial. I just wanted to show you that according to the criteria of phase 1 to 3, interventional study type of study completed with results, there is a huge effort for this rare disease for targeted therapies, either as monotherapies or as a combination, for immunotherapies, for antibodies, vaccines, anti-angiogenic agents. They're really trying to do some effort over there and have something beneficial. So it was only in 2021 that we saw a little bit of light in the horizon with Tebentabusp, also known as Kimtrak, that's the commercial name. So tebentafusp is a bispecific fusion protein that connects the GP100 expressing neoplastic uveal melanoma cells with the T cells through CD3 activation. And as we can see here in the first results, we have a benefit in the overall survival of tebentafusp treated patients compared to the control ones. However, a 3 years follow-up, so this red line depicts the end of the first graph, a 3 years follow-up shows still a benefit, but a benefit that decreases. And the most important disadvantage of this therapy, unfortunately, is that the patients need to have a specific HLA allele, the one that you see here. And so 9% of the patients actually respond to this treatment. So what we can summarize from this is that we have the primary disease, we have local tumor control, we have metastatic disease, and nothing that works for every patient. So still 90% of the patients suffer from metastatic uveal melanoma. And so there is a critical need to identify efficient and global therapies for all the patients out there. For this, we can use virus research strategies, and I'm just going to give you an example here of what my lab did prior to my arrival. And so like every fundamental research, we start with a cellular model that helps us to work in a standardized environment. And for example, also for me, for my research during my PhD, I used these cell lines that they derive both from human primary disease or metastatic, either from liver or skin metastases. They harbor different types of mutations, as you see here. There's a whole panel. They express BAP1, which doesn't cover the BAP1 loss in the cell in the human tumors, unfortunately, but that's because BAP1 deficient cell lines are very difficult to grow in culture, and they have a particular chromosome 3 status, as we have said before. So using the cell lines, and just to complement an extra information is that we use different cell lines, and the more the better. That is because if they carry different mutations, we can actually reflect our discoveries into a broader field of genetic diversity among the patient's population. So the more cell lines we use and the more common elements that we find between the cell lines, this can rise the possibility to cover a bigger, a wider genetic background in the patient's population. So like I said, excuse me? Okay. So a dropout genome CRISPR-Cas9 screening was conducted prior to my arrival, and they identified genes essential for proliferation and or survival of metastatic uveal melanoma cells. And we're going to go, it's a very big title, a little bit intimidating, but we're going to go one by one the words to explain it. So it is a dropout genome CRISPR-Cas9 screening because it's a negative screening. That means that the cells in which the genes have been efficiently knocked out, they will gradually get depleted from the total cellular pool by the end of the experiment. It's a CRISPR-Cas9 screening because we have, of course, you know, the acronym is the Clustered Regularly Interspaced Short Nobel Prize of 2020 from Dr. Doudna and Dr. Charpentier. And what is CRISPR-Cas9? It's a tool that helps us to modify the DNA. Where is my video? That helps us modify the DNA of many living organisms, such as, for example, animals, plants, insects, and humans. This method is based on the adaptive immune system of bacteria, and once against the viral infections, and once the bacterium senses a virus, it produces a complementary sequence to the virus known as crRNA, and another sequence which is tracer RNA, and all these three, they become a complex along with the Cas9 protein. And once they found their target, they cut the gene or they cut the sequence like molecular scissors, inactivating the virus. So the last few years, researchers has take advantage of this method, and they genetically modified with precision the DNA of organisms. And so they see that when the complex forms inside the eukaryotic cell, we can cut a gene, we can delete a gene that we desire and follow its effect. Okay. So why genome CRISPR-Cas9 screening? Genome is the total set of the protein kinases that are encoded by the genome of an organism. They're enzymes, they're phosphotransferases, they're major regulators of complex cell processes, and their subcategories, tyrosine, threonine, and serine, have been well studied compared to other molecules. In a pharmacological point of view, their major targets in oncology the last 30 years. Their large size offers us many molecular options if we want to identify therapeutic targets. Their active site is conserved, so they're druggable targets. That means that they have in between them, they share similar structure and function. And many kinase drugs we have seen so far that they can be repurposed, or they will be repurposed from one disease to another. And specifically for uveal melanoma, just to remind you, a number of alterations are correlated with the activation of several kinases, and MAP kinase pathway is a common event in this disease. So CRISPR-Cas9 screening workflow looks like this. So, for example, they have used the representative human OMM 1.3 metastatic uveal melanoma cell lines. They infected these cells with single guide RNAs. They infected the cells with the human Genome Brunello library, which is commercially available from Adgene, and it targets 760 kinases. The cells were subjected to puromycin selection. This is a technical detail. Then they performed the proliferative screen. And then from the cells, from the in the end of this screen, they extracted the genomic DNA. This was subjected to next generation sequencing analysis. And then through a software known as MAGIC software, they performed the bioinformatic analysis. So this workflow allows us to go from pool of genes to potential targets that affect the proliferation or the metastatic capacity, the survival capacity of metastatic uveal melanoma cells. And like I said before, in the lab that I was, they published a wonderful work in EMBO Molecular Medicine in 2023. And I invite you to see the research paper after my presentation, because I'm just going to show you a few key points that they did with some experiments. So they showed that LQB1-SIG2 loss drives uveal melanoma proliferation with an implication of SLC8A1 and ROS inhibition. So, like we said before, with the CRISPR-Cas9 screen, we can identify potential targets. And this screen has shown that LQB1 loss is critical to regulate the metastatic uveal melanoma proliferation. But just like every screen, we want to validate this result in case we have off-target effects or false positives. So by using single guide RNAs, 3 different ones, they monitored the protein level of LQB1 in this Western blot analysis. And they also saw with the proliferation assay the corresponding phenotype. And indeed, LQB1 loss promotes, favors even more the proliferation of metastatic uveal melanoma cells compared to the control conditions. Usually for this type of results, we want to have a rescue experiment which shows the causality, and it is an experiment that shows how we can restore the phenotype by adding back and shows the specificity of this phenomenon upon the deletion of the candidate LQB1 in this research work. So as you can see here, when we delete LQB1, we have higher proliferation compared to the control one. When we add back the kinase dead form, and just to remind you, when we talk about kinases, usually we need the full kinase form in order to be active. So when we add back the kinase dead form, we pretty much have the same effect when we delete LKB1. But when they added back the wild type and they restored probably the cascades, the molecular cascades inside the cells, then the level of the proliferation drops back to the same level as the control one. And this works, the rescue experiment, we say that it works like an on and off switch. And so these experiments and many more that they show them on the paper, indeed reveals that LKB1 is directly responsible for the observed phenotype. Next, they wanted to go a little bit closer, let's say, to real life to real life conditions. Closer from cell lines is the in vivo experiment, and they used mice where they inserted xenograft tumors via subcutaneous inoculation. And indeed, if you see the two conditions where LKB1 knockout, meaning LKB1 deficient tumors, they tend to grow way more compared to the ones that they have the wild type. And so that means that indeed the fact that we have seen in the proliferation assay is similar to the one that we see in a real life, real organism matrix such as the mouse. When we validate the phenotype and we validate the results, we want to see what are the mechanisms behind this specific phenotype. So they perform here a transcriptomic analysis with LKB1 knockout conditions compared to control ones. And they have seen a number of deregulated genes up and down. And one of the top hits that popped up was SLC8A1. It's a solute carrier family 8 member 1, if I remember well. And it's involved in the intracellular metabolism of calcium. Next, they perform another analysis, which is close to transcriptomic, but not the same, the gene set enrichment analysis. And they have seen a particular enrichment in the hub of calcium metabolism again. They perform another set of other experiments for qualitative characterization, and indeed, it has been validated. And of course, they performed a rescue experiment where, as we take the result from the transcriptomic analysis, when we knock out LKB1, we have a higher expression of SLC8A1. When we put back the kinase dead form, we don't have much of a difference. But when we get back to the wild type form, we have almost the same level, or it drops close to the same level as the control conditions. Again, we have a successful on and off switch. And if you see in the upper part of the slide, we are slowly but gently creating something that we call molecular cascade. So we have the first part, which is the LKB1, and then we have a potential downstream target, which is SLC8A1. We don't know what happens in between. We don't know if SLC8A1 has the same impact as LKB1. So for this reason, they did a number of other experiments to validate the downstream target. And indeed, in LKB1 knockout conditions, where SLC8A1 should be overexpressed, they used an sRNA gene silencing protocol, another inhibitory technique, to reduce SLC8A1 in mRNA level and in the protein level. And they saw the opposite effect, exactly what we were expecting after the inhibition of both molecular targets. And so SLC8A1 partially controls the proliferative capacity. So in another level of discussion, LKB1, according to scientific literature, has many downstream targets that have been well studied. However, in this CRISPR-Cas9 screening, they have seen only SIG2, which is among the downstream targets, to go in the same direction as LKB1. So they thought that it would be a good strategy to focus on SIG2. Indeed, they perform another validation of the functional impact of inhibition of SIG2 with individual single guide RNAs. And as you can see, it exerts exactly the same effect, so higher proliferation rate compared to the control conditions. They also performed rescue experiment that was good. So the switch is on and off. So that gives us specificity, that gives us link between these two. So we have created the first hub, which is LKB1 affects SIG2, but do we know if SIG2 affects SLC8A1? That still remains the question. And so, of course, they performed another set of experiments to prove this link here, this association. And so, indeed, by putting back SIG2 in SIG2 knockout conditions or putting back SIG2 in LKB1 knockout conditions, it again, the active form, it drops back the same level of SLC8A1. So it is validated that SIG2 regulates SLC8A1. So we spoke before about calcium metabolism, and it's known by scientific literature that high mitochondrial calcium results in high mitochondrial ROS, which has a proliferative and survival advantage of cancer cells in most of the cases. So they also validated with another set of experiments, and they have seen also that LKB1 or SIG2 loss results to a higher, as they call it, addiction of metastatic uveal melanoma cells to calcium. And the same happens with LKB1 or SIG2 knockout for the mitochondrial ROS. So they thought, okay, instead of targeting these molecules, why not target the mitochondrial ROS? Another experiment of flow cytometry has shown that when they used the mitochondrial targeted antioxidant mitoquinol and in combination the SLC8A1 inhibitor KBR7943 exerts some effects towards the increased apoptosis of metastatic uveal melanoma cells. When they did only the mitoQ in LKB1 or SIG2 knockout conditions, they saw no transfer of the cellular population towards the apoptotic part, because in flow cytometry, annexin-5 is usually used for the to monitor the apoptosis. When they used the SLC8A1 inhibitor, again, they didn't see much of a difference, but when they used the combination, they saw a good shift of the population towards the apoptosis. So they suggest, how about co-targeting the SLC8A1 and the mitochondrial ROS? And how about this, if it could be developed as a therapeutic option? Before, of course, going to the clinical trials and starting speaking about development of therapy, we want to see some preclinical implications. So they did exactly the same thing that they did here with uveal melanoma cells. They did it with, they performed an experiment in vivo using anthemic nude mice, which they subjected to subcutaneous injection. And so they compared the treated conditions with the control one. This is the empty vehicle of the experiment. This is the control of the experiment. And so indeed, when they used the SLC8A1 inhibitor, we don't have much of a difference again, or mitoQ alone. But when we do the combination of these two, we have a significantly smaller size in our tumors. So this is an extra scientific argument that this could be a potential, that this could develop as a therapeutic strategy for uveal melanoma patients. So now I can actually confidently tell you that indeed LKP1 SIG2 is part of the molecular landscape of uveal melanoma, and the loss of these two drives the cellular proliferation of metastatic uveal melanoma cells. But having research results and going and exhibiting preclinical results is very nice. However, there is a real need out there for patients, and entrepreneurship could be a potential step on how you can transfer your research work from the lab to something which is concrete for the patients out there for their benefit. So I'm going to talk a little bit about entrepreneurship for a rare cancer. I'm going to give a few definitions just to make sure we're on the same page. So biotechnology, it's a multidisciplinary field based on the application of biological systems or organisms or derivatives of these organisms in order to develop technologies and products that improve human health and the environment. The goal of these companies is to create innovations in healthcare, agriculture, industry, and environmental sciences. And some examples you probably have seen, there's gene therapies, bioengineered crops, or pharmaceutical development. But like every endeavor, even the ones with a higher cost, they have challenges. So I have divided the challenges into two groups, the scientific and research challenges and the financial and funding challenges. So usually, especially for rare cancers, we lack appropriate models such as animal models, cell lines, PDX, or one of the most important arguments is that we have a small patient population, which also impacts the clinical trial design later on. And for the financial funding part, we have limited access to funding, especially to the non-dilutive one, just like grants or crowdfunding. And for example, crowdfunding is affected by the limited awareness and advocacy for this kind of diseases, meaning that you have less funding possibilities. And in another step, in another layer, we have the pricing and reimbursement challenges. That means that when we get to the endpoint where we develop these therapies, how do we deal with the cost? How do we deal with distribution? And this is between either national, international, or worldwide associations that you have to deal to make deals and to make arrangements for this. And a huge, let's say, enormous lines of regulations and guidelines. But there are possible solutions that can help you with this kind of challenges, such as collaborating with academic institutes. You can develop shared resources, such as specific lab equipment that you have, or some specific techniques or protocols. You can join the Rare Disease Consortium that you can have access to a large data set, and especially through artificial intelligence, you can make some first steps without needing any wet lab experiments before. Usually they follow adaptive clinical trial design, and the establishment of global collaborations helps you to have access for patient population in other countries, while this usually also requires significant research maturity due to genetic differences. For the financial part, of course, the golden standard is to have non-dilutive funds, leverage orphan drug incentives, for example, orphan drug designation from FDA in US or EMA in Europe, which includes reduced fees, market exclusivity, etc. Engage mission-driven investors. That means, you're trying to find people that they want to fund and they want to financially support you just for the cause, or primarily for the cause, not for the benefit, not for the market. You're trying to raise awareness with educational campaigns, and of course, use the incubators and accelerators as a safety net to mature your company enough before you go out there. So I'm going to finish this presentation by talking for a biotech, Roca Therapeutics. It's an example of a biotech for metastatic uveal melanoma. It's based in Nice. And I had the honor to meet one of the co-founders, Dr. Maëva Dufis, in one of our sessions from Nucleate France Unicia, the organization that I'm an external advisor. So it's a biotech that they do first-in-class drug candidate development for uveal melanoma, primarily. We're going to focus a little bit on the RCT-001, their active compound against metastasis of uveal melanoma. So it's an orally available small molecule. It's an inhibitor. and it targets these long whatever names are here. But what is the most important is that this axis here is involved in angiogenesis and inflammation. So you're targeting to block angiogenesis and inflammation of the tumor. They work with a workflow that involves drug development, sorting the options, optimizing the compound options, and evaluating them before they move on to sell to big pharmas. And their goal is also to expand their discoveries to other ocular disease, like glaucoma. And I also had the honor to and the privilege to be able to quickly interview Dr. Maeva Dufis. And so I can offer you here some real life testimony of how it is to have a biotech for a rare cancer. And so, for example, for the lack of appropriate models, she told me, especially for uveal melanoma, because we know that there is no immunocompetent mouse model which is appropriate for the uveal melanoma. They used alternative animal models such as zebrafish and chicken embryo. They used, in the end, the immunocompetent mouse for other cancers in order to demonstrate the drug's efficacy in a whole organism. And quoting her words, in the end, you want to deliver something with as much as like minimum toxicity that you can have, because the truth lies in clinical trials. For the small patient population and the clinical trial design, she told me that they follow two strategies. I think these are the general strategies that you have for clinical trials. You can have the slower one, but more specific with patients from uveal melanoma only. Or you can have patients with other cancers, including uveal melanoma, which is faster but more diverse results. And again, you need to have a particular research maturity in order to translate the results that you will obtain from the second approach. And lastly, they have a geographical advantage, and someone has to work with what they have. So in France, there are two centers, two institutes that they treat patients with uveal melanoma. I think one is here in Paris, and the other one is located in Nice. It's the Saint-Antoine-la-Cassagne. So they could have straightforward collaborations with them about the patient population and the clinical trial part. For the limited access to funding, like we have seen before, they develop compounds for uveal melanoma with the possibility to extend to other cancers. So this is an argument that they use for the investors to tell them that they will open up to other markets, for other diseases, etc. And for the pricing and reimbursement challenges, they have chosen not to deal with it. Once the drug is finished, they will sell it to a big pharma, and they want to continue to grow. Like their main goal is to continue to grow as a biotech through their pipeline of discoveries. And one last challenge that it didn't even cross my mind, and I found it amazing as a quality of the character of this researcher, is that she told me that the most difficult challenge is the ethical one, because quoting her words, it can be complicated being contacted by patients or patients' family who ask you when your treatment will be available because they've reached a therapeutic dead end and they're seeking advice. It is not easy to deal with it, and it always hurts. I always try to be positive, to reassure them and to remind them that I'm not a doctor and it's the doctor who can best advise them. So it's as I've seen, and also from other people that they have talked in our nucleate events, biotech founders, as I've seen, it's a very rich and full journey. However, it has challenges, which sometimes are quite difficult. But what I see that drives these people to continue their effort is that even if they're rare diseases, in the end, researching these rare diseases is important because you gain unexpected insights into fundamental biology that could be translated also for other diseases or cancers, etc. And if you put all of the diseases together, I think the orphan diseases count from 3.5 to 7% worldwide. This translates to around 300 to 500 million people. And rare genetic diseases are collectively common. If you put them all together, in the end, they're very common. So, quoting the words from another researcher and medical doctor, Dr. Anna Greca, which I wish I knew her because she's in MIT and Harvard, but who knows? In her TEDx talk about the rare diseases and why we should keep going on and investigating these kind of conditions is that from a few to more and more until we have precision cures for all, because each patient is a patient, even if for the numbers it's just numbers or for the statistics just statistics. Each patient deserves a better quality of life, prolongation of life, all the therapeutic benefits that could have as a person who gets treatment. Thank you very much for your attention. And if you want to contact me, these are my email, my LinkedIn profile, and of course, I'm available now for discussion. Thank you very much.
Wow.
I hope it wasn't too boring.
Dr. Quinn was on the edge of his seat the whole time. So, God, I don't even know where to start. There's a couple of questions in the comments. So, we're mostly deal with clinicians and those kinds of things. So, this behind the scenes, research is not something that I've see a whole lot of. I don't want to speak for everybody here, but it's a fascinating world when you look at under the covers, I guess, or under the covers. So I told you guys last week that she was smart. So
No. I'm just stubborn because it requires
right.
a tons amount of work and laboratory time.
Yeah. In the chat, there's a couple of articles that have been highlighted that are there's links to. So I can't look at them myself because I'm the host here, but they're I'm not sure what they are. And the first comment is from Robert Fortier something BER, and it's in French. So I don't know what it says. Because
He just thanks me that I'm here.
okay.
Well, merci beaucoup,
Okay.
Monsieur Robert Fortier-Benson, if I'm saying correct. I hope you like my presentation, and it was. I hope everything was understandable. I didn't want to sound too much research. The goal is to understand, not to show off or.
So I'll ask a few questions in the comments, and I'm not sure, is Dr. Nario still here? Do you have any questions online?
Yes, we do.
All right. So let me ask these first. Could you comment on vitamin D levels of patients in your studies? Do you look at those at all?
Also, first of all, I don't do clinical studies actually, and I didn't use biopsies for my PhD research.
Okay. All right. Yeah, we were at an integrative dermatology conference about a year ago, Dr. Nario and I, and there was a whole hour talk on vitamin D levels in melanomas. So
but what type of melanomas? Because as I showed previously, uveal melanoma is very, very, very different of cutaneous melanoma and proven to respond completely different to therapies.
Okay, and that's the
actually non-response.
That's the next question. Is there any risk that
it's more cutaneous? Yeah, I remember. Dermatology, that.
Is there any
risk, the cutaneous one?
Is there any risk for those who have skin melanomas or cutaneous melanomas that it either is the etiology is the uvula or it can metastasize there?
So I don't know. So far from what I've read, if you have skin melanoma, that cutaneous melanoma, because it depends. Different types of skin you can have different types of skin cancer. So if you have cutaneous melanoma so far, it does not mean It doesn't count as a risk factor. I don't know if there is any research, like later research work. So to my knowledge.
Okay. Have you seen any effect of melatonin to suppress the micrometastasis? Is that something that you would?
Not in my research part, because I didn't do any. Actually, I tested a few drugs to target my own protein, which, like I said, it's unpublished results yet. They're supposed to be non-specific inhibitors of my protein, for example, and I didn't even see the inhibition and effect even from these drugs. So let alone melatonin, which is I'm going through this scientific point of view. If it's a non-specific inhibitor, I'm waiting a lot of off-target effects or off-target phenotypes, and even not working at all. But this is just speculation.
I have a quick question, Dr. Clearfield.
Yes, go ahead.
You said it's fair-skinned people who have a tendency of having this melanoma. What is the environmental effect, pollution, or anything like that towards these melanomas?
Not a research study proving a direct link of environmental pollution to uveal melanoma so far.
What about the sun exposures or anything like that?
So for the UV radiation, there is one research study, I think somewhere here. If you're interested to see, there's only one, I think, one research study that they tried to find genetic signature. And it was only in a few cases of iris melanoma that there was an association with UV signature. Yeah, it's Johansson Nature. I think, no, it's Shields JAMA Ophthalmology 2013. So it was only this one that showed. However, it showed association not being a primary risk factor. So far, no UV radiation signature associated with UV melanoma, which is also depicted by the southern to northern latitude higher rate, which is contradictory if we had a UV signature.
Right. Now, did you look into Australia and other places, the prevalence worldwide of this uveal melanoma?
So for my research, like I said, I didn't have any biopsies because I wasn't doing this part. For the slides that I showed you, initially I had only the European one. So I added last minute the US one. And for the worldwide, it's a very, I think it covers US, Canada, and Europe, if I remember well. So it doesn't cover Africa, Asia. That means it's not worldwide on one hand, but on the other hand, you have to work with the statistics that you have.
Right. Okay, very good. Thank you.
So, can you hear me, guys?
Yes.
Yeah, good. I'm Dr. Halase here.
Hello.
We have a case, and a nice presentation, by the way. And it happened that I also invited Dr. Joseph James because we are working on a case with uveal melanoma. I don't know if Dr. Joseph is hearing me or not, but I did invite him here. And this
I'm
case,
here.
oh, good. So I will introduce it, then Dr. Joseph, you can go ahead and continue. But we're looking for doing immunotherapy. She is HLA positive, which is good. Yes, she has a blue eye, which is something that you mentioned about the risk. And we are thinking about using Chemtrack antibodies, but we want to load inside platelets nanoparticle using nanomedicine technology so that we can target it into the pathology versus going everywhere. And we're also doing a lot of integrative therapy for the patients, including polyphenols and also planning to do photodynamic therapy with indocyanine green and methylene blue. There's a good article about photodynamic therapy using indocyanine green and methylene blue, and then activate them with infrared light and red light, and possibly help to induce apoptosis in those tumor. But as a combination of immunotherapy for the dynamic therapy, do you suggest any chemotherapy or any other things that we can, integrate it in our cocktail? And then I'll let Dr. Joseph to even follow up after me.
So first of all, I cannot take the decision because I'm not a medical doctor. From a research point of view, the thing that it's available out there, it's the FDA-approved KIMTRAC. As long as you follow, I think, the protocol, and this you have to talk with the corresponding people. And if she's HLA positive to the specific HLA that's required, that means there is a match. Other than that, right now in research, we don't have something extra. And if you want to have more information, for example, I can bring you in contact with the ophthalmologist that we had in my laboratory, and he can provide you extra insights because he also treats uveal melanoma patients. And he's also doing a PhD in our lab. So he's really in both sides, medical doctor and research. So on my side.
That would be great. Dr. Joseph, are you there? If you can, we can get her phone number, your phone number, the other doctor phone number, and see if we can collaborate and possibly publish it. Are you there, Dr. Joseph?
Yes.
You can find me on LinkedIn if you want to send me a message, drop me a message, and then I can give you back the email and the phone number of this doctor.
That would be great. I think WhatsApp phone number, it's a good thing too, if you have. But LinkedIn, I have LinkedIn, and Dr. Joseph has LinkedIn. But go ahead, Dr. Joseph, you want to add something here, because it's a case that you're taking care of.
Yeah, just unless you may have answered this already, but have you come across any cases where the patient has had full remission, or possibly the word we're not supposed to say, cure?
No, I have not been involved in this type of. It's mostly, this is what we call the clinics, and I'm not there. I'm way behind.
But you didn't.
So that's why I told you to have. Thank you.
No, I mean, just in your exploration and researching, have you ever heard of any cases where a patient had this diagnosis and they did not have to have enucleation, they did not have to, they did not metastasize, and they lived? And
No, not that I don't know. This kind of information I've never searched.
okay,
but it's a good question actually, because there is a remaining 20% that remains. Yes, please.
Hi, this is Dr. Patel.
Hi.
Have you, in your experimental studies, how much regression have you seen of the growth?
Well, in my study, which is the opposite thing of the research work that I showed you before, I have seen around 70 to 8% reduction in the proliferative capacity. And when I perform Boyden chamber assays, which is an assay where you can kind of like model the metastasis of the cancer, it's the transwell migration. It's a very standardized environment and a very artificial one, but it can give you a hint. I also saw around 60% of reduced transwell migration capacity. So I hope that it can move after my departure from the lab, and it can be developed in therapies.
The immunotherapy that you are using, is it available
I'm not using
on an
any therapy.
basis?
I'm not a medical doctor.
No,
and
I understand that. I understand that. I understand 100%. But what I want to understand is the molecule that you are using, is it available on an experimental basis?
You mean for my research? Because for my
For your
results,
outside your research, if you want to try, is it available?
the ones from the clinical trials, you mean?
Yes.
I think not, because since they did not pass the phases of clinical trials, they're not approved.
And do you have any results of your clinical trial where the progression has been stopped and there were no metastases?
No, because I'm not focused on this subject.
No, you are not focused, but you have not integrated that your research in a clinical research. Is there is any overlap, or there? I mean, usually the experimental, whenever they do it, and then it's followed by the clinical research, and they try to see that if there is any clinical improvement which is noticed similar to that of the experimental research. And you
Well,
say that in
mm,
experiment that you saw 60-70% reduction in the size and more than 60% reduction in or no cases of metastasis. So I just want to see that whether it was there any clinical imposition of the same thing.
so not yet, because at least for my my PhD results, if you remember the previous slides that I showed an example of this research strategy being in a scientific publication. I'm at the level where, or at least where I left, we were at the level where we're trying to characterize the mechanisms behind the effect that we see, behind the effect of lower proliferation or lower migration that we see in the metastatic uveal melanoma cells. And this requires quite a few time to be able to have concrete laboratory results before we move on to potentially develop an inhibitor or use the non-specific inhibitors if there are any that they work, and then move on with in vivo experiments, so to have the same results in an animal model, for example, and then move on to the clinical part where it's phase 1, 2, and then hopefully 3. But this is too early right now, and this is going to
So
take
have they done only phase 1 or phase 2?
No, we're still in the preclinical part, just characterizing the mechanism. Well, not just, because it's a huge amount of work, but and when I left, we characterized the mechanisms that we see the phenomenon in the in vitro part, meaning cells in cell culture.
So, have you done any anti-PD-L1 or anti-CTL4 immunotherapy? Did it work for this melanoma?
No.
Well, she's not a clinician, so Dr. Halazite is not a very
right. She doesn't do that.
But even for in vitro experiments, I was not involved in the immuno part.
Okay.
Mm-hmm.
You had a BAP1 gene, right? You from what you showed, it's classification 1, 2, and classification 2, A and B or whatever it was. And you just show in that there was a BAP1 gene, and that was the responsible for more aggressive nature of the tumor, right?
Yes.
Yeah.
When you have a BAP1 loss.
So most of the time in clinical cases, we do not have any biopsy results or any. They told us that we cannot do biopsy of the patient because I saw that patient first, and she did not get the biopsy, but we were able to reduce it considerable. And then after probably 6 weeks of not receiving it, and then she started getting it, and I think she has not developed any, as long as I know, has developed any metastasis. Correct, Dr. Joseph? Dr. Joseph. Okay, he's not there.
Dr. Joseph, his voice today is not good. I don't know. He has some throat
Yeah,
problem.
yeah, I heard that. Yeah, but I as long as I know that she doesn't have yet the metastasis, which is like she has gone almost 8-9 months, with and after beginning the treatment probably. So I mean, she has good progress, but you know what we want to know. I mean, there are some patients that I know that no enucleation was done, and after 10 years, still the tumor is still in the eye, and they are okay. So they may be of the characteristic what you showed in group 1, that did not have a BAP1 gene, and
I'm here.
yeah, so it may be a good idea to see, but unfortunately, we cannot have any biopsy on this. They just want to enucleate her eye,
What about
and
circulating tumor cells from RGCC? You think they can do some DNA analysis on it if there's any circulating tumor cells?
yeah, they have done it. They have done it, but not for these genes.
Yeah.
But I mean, if we ask them, maybe they can. I think they should. We can contact them and find out.
Yeah, I have good connection with RGCC now, possibly working with them, helping them. But I'll see if we can connect with the MD side of the French doctor as well, so he can help us to give us some other inputs and other experiments. That would be good. I already add you on LinkedIn, Dr. P, and I wish if you could add me, and then we can invite the other doctor possibly in my Monday meetings. Can he comes and I have a Monday webinar, and maybe you and him and Dr. Joseph and Dr. Patel will get together and see if we can add more to the table here.
So he's based in Nice, and he can of course participate, I think, in a web if he's available, because he also works a lot. And the other thing I would tell you is that I've shown you in previous slide, maybe I can share again, is that there is a specific prognostic tool that they use, and it's available in US. So I'm sure you could search for it, the Decision DX Uveal Melanoma by Castle Biosciences, that predicts the metastatic risk of uveal melanoma patients. So if I could say something, is you can go and search for this and ask information and how you can apply this for your patients, for example.
For normalcy, they voted for Trump, and
Can you find out one of those Mondays you and him will or even for Tuesday for Dr. William, doesn't matter. They were all the same team. And we can have another meeting and discuss this, because we have a patient here, and plus I have another lab which is RGCC, and I can bring them on the table to see if we can translate this into more clinical oriented or more clinical perspective.
Yeah,
I can provide you his contact details, and then you can set up a meeting with him, because that depends on his availability, of course.
So I'll send it to me, and I'll make sure that you get it. Okay.
Yeah, I just wanted to chime in just really quick because for some reason I had some issues with the app. No, the patient has not metastasized, and her CEA has gone down to normal. And the only other question is, this tumor mass is it just scar tissue? Could that be the case or not? And that's another question we're trying to find out. And we're trying to also reduce the scar tissue with like losartan eye drops and yeah, and we should probably retest her to see if there's evidence of metastases.
I cannot answer to that, because that's more of a clinical side.
That was more in response to Dr. Patel. I was just answering her question. I couldn't get on when I was trying to.
Dr. Joseph, if I can chime in there. So working with cancer for almost like 6-7 years, melanoma is really one of the harder pathologies to treat. And with cancer markers, really CEA is there's no known cancer markers for melanoma. so far. And though CAA can be any inflammatory condition that can come up, that can help also, but it's not specific. And in regards to RGCC, us working together for that long, even then they would actually tell us that circulating cancer cells are not accurate diagnostic markers in relation to the clinical progression of a cancer. So meaning the clinical presentation still trumps the CTC number of RGCC results. That's why it can be used in some specific cases, but if you're going to decide your clinical management on a circulating cancer cell or CTC number, that's probably something that they wouldn't advise. So it's always going to be a combination of different diagnostics and assessments of the medical practitioner.
Okay, thank you.
Okay. You have any questions on the email there, Dr. Nario?
Yes. So Dr. Evangeli, there's a lot of thank yous for you, and very interesting talk. And one of the things that I think struck our viewers here is MitoQ. So we had MitoQ already on board who spoke in our webinars, and it's actually mitoquinol as their, I think, main ingredient. What is the theory behind this? Is it because it's a CoQ10 that goes through the mitochondria? That's why it's more effective. That's why it works with your other inhibitor. Is there something that got derived from your study in relation to the effectiveness of MitoQ?
So it's not my study. It's the research from a scientific paper from a colleague researcher from that lab that I did my PhD in, and that's why I presented it. But just for this, so far they have not characterized exactly what are the molecular, let's say, interactions and the molecular cascades in detail. What they have shown is that from the results I showed you before, if you want, I can open actually. I know it's too much science and can be super boring, but that's our side. So
That's okay with us. We like those type of things.
So
and
what
do
they
you have dosing also? I think that's one of the questions since you're at it.
Yeah, I need to search in the paper so I can. I did not write it down. Yeah, I know. I should have. My audience is medical doctors. I should have. I know. So we pay attention, but it's not our primary goal. So as you see here, after they have seen the phenotype, which actually it's the opposite of what we want to do with cancer cells, because when we inhibit LKB1, we have higher proliferation in metastatic uveal melanoma cells. So what we want in a hypothetical scenario, what we want to do is we want to have, let's say, a tumor. This is a very general statement, what I'm going to say here, and a very simplistic one. We want a tumor that has LKB1, which is a tumor suppressor gene. We don't want a tumor that has lost its LKB1, because if it has lost, we see a higher proliferation capacity. And so after they have observed this phenomenon, they wanted to see what are the mechanisms. They wanted to characterize the mechanisms behind this phenotype that we see. And so they identified the calcium metabolism implication in terms of SLC8 as a top hit, the gene enrichment analysis. And then with some other experiments that they have done, they identified higher addiction to intracellular calcium and mitochondrial ROS. So I think besides this, I mean, if you want, you could check it with even more detail, the publication. They applied the treatment and they suggest that co-targeting the SLC8A1 and the mitochondrial ROS as a therapeutic option. But from these experiments, which these are cells in a flow cytometer, these are cells that have been developed as tumor inside an anthemic nude mice. We have many more steps in between to take in order to safely suggest to medical doctors later on to use it for therapeutic benefit.
Well, the important key there is, as you can see, MitoQ is basically a very good synergistic therapy in relation to that specific slide that you just shown. And why is that significant for us? Because again, as we've been working with RGCC, we have this ability to test for natural compounds that actually can help with our cancer therapies. And RGCC, I don't know if you're familiar, but that's also, I guess, in Greece. This was what we call it, the Greek test. But anyway, for clinicians out there, that's something significant. And I think what the product was emphasized on that slide was actually the plain MitoQ, because there are different types of MitoQ, MitoQI, MitoQ, I guess even cardiovascular, and I think that's pertaining to the plain MitoQ there in that specific slide that you showed. Another one would be, so you mentioned about the risk factor of aging. So this is probably a good question. That could you relate this probably to the telomerase activity that is decreasing as aging moves forward and thus makes us susceptible for this type of cancer? Are you familiar with telomerase?
Question. Yeah. Good question. I'm not sure, or at least I think I've not read any publication which associates, I think, telomerase activity and uveal melanoma.
Right. I mean, again, I think they're talking in general here, just because as you shorten your telomerase, that of course the telomeres decreases in length and thus more proneness to cancer does occur, not only in specific melanoma cases, but in general cancer. I think that has been proven. Another one is the question of, so you showed CRISPR. Have you heard of the technology called superior oligonucleotide therapy, or SOT? Okay, so that's something that's also, I think RGCC is working on in relation to they even label that as a cancer vaccine that actually produces a messenger RNA, reproduces a messenger RNA from your cancer cells that prevents the proliferation of the cancer itself and not affecting normal cells in the system as you infuse this in the body. But I guess CRISPR is just almost similar to that technology in a specific way. And anything that, according to your literature search, about regular chemotherapy that could actually make your uveal melanoma respond to it, or is just specifically immunotherapy that you've seen on your literature search?
So only for the tebentafusp so far. For the other therapies, actually for the other inhibitors, for example, they show an effect in vitro, but they're still under clinical trial in case they can be optimized or can be combined with something else that resensitizes the cell to some beneficial phenomena like apoptosis or senescence or whatever. So far, it's a tebentafusp, which only 9% of the patients are responsive. So that's why it's so lethal, because it acts fast, and we still don't have any treatment. Even the treatment that could prolong the survival of a patient.
Right.
Globally for all patients, not only for 9%.
You mentioned something about calcium channel, that those melanoma, they are activated with calcium. So have any trial has been done with calcium channel blockers, like nifedipine or verapamil or anything like that blocks the calcium channel, may help with those patients?
I spoke about cancer metabolism because, like I said to Dr. Nario, for the calcium addiction, they don't know the exact mechanism. They just show the results and the cluster of genes that have been deregulated behind this phenomenon. So we don't know if they don't know, or it has not been shown if it's calcium channel. To my knowledge, or at least the clinical trials that I've seen, this is a compilation I did, the tables I showed you until July 2024. I think not, if I remember well.
Well, there is some publication using nifedipine and verapamil as a calcium channel blocker, potential treatment for uveal melanoma. So it seems like there's some active or target for blocking those calcium channels, and there are many types of calcium channels, but there's a potential for the L-type calcium
Is it
channel
completed
blockers.
with results? Because the clinical trials I showed you are phase 1 to 3 interventional completed with results.
No, this is just potential. They are just it's for you to try and see. That's why we are bringing this on, because those are things that anything that's FDA approved, it's easy to repurpose it and easy to be applied on the patients. That's why we want those researchers to consider all those generics that's already FDA approved, so we can translate it clinically fast and apply it. Versus if you create something out of the blue, a molecule, it will take another 100 years for for this drug to be used by clinical. So I think those researchers, it will be great if they start thinking, more practical and see if they can repurpose drugs that's already FDA approved.
Well, this is one of the axes that even for my research or other people that they have done research we're trying to do. It's just that we have to bring you guys results, and we have to deliver results that they have specific mechanisms behind, that they don't affect. For example, this is a good question that they asked me during my PhD defense, that what about the effect on the healthy cells? So I can have a wonderful effect on the metastatic uveal melanoma tumor, and then have a number of side effects, severe or not. So this is something that we're also trying to, of course, avoid.
That there is some way to overcome that. That's what I'm trying to introduce here to the clinical word, nanotechnology and loading drugs inside cyclodextrin and platelet nanoparticle. When you do that, then you get those drugs moving to the cancer tissue versus the healthy tissue. So I want you also in your work, and hopefully that we can collaborate in a bigger scale with our team of doctors here or integrative oncology to see if you can apply nanotechnology and possibly to minimize the side effects of those drugs who has potential effect on the healthy tissue.
It could be, of course, it could be a potential. Anything that can be beneficial for the patient, and it shows result, of course.
Yeah.
Okay.
I did add you in your LinkedIn. I wish if you can add me, and then we can communicate, and possibly whether on Tuesday or Monday, whatever the doctor is available, we can accommodate from our side here.
Remember, Dr. Halassa, they're in Europe. It's the middle of the night. We need to let this young lady go to sleep.
Yes, no, I have all time, no problem.
There is a in the chat here from Dr. Fortier Benson to let you know that there's a vitamin D link with uveal melanoma. There's a study, vitamin D receptor hydroxylases, CYP27B1 and CYP2A1, and retinoid related orphan receptors. He didn't give
that's interesting.
He didn't give me a link to it.
So it's good. I come here and I learn extra articles that usually us in the lab, we don't pay too much attention. So it's also helpful.
Well, you're actually doing stuff. We just kind of pretend.
Oh no.
We're
copying you. We're learning from you.
Yes, we learn from you.
No, I'm not one of these, and there are many researchers, but we don't think this. Each field does its own thing, and we all work for a cause, which is very important. We do our work, we do what we do, you do what you do, and in combination, we can help patients. That's the most important.
Okay, there you go. Okay, any other questions, Dr. Nario?
Well, yeah, everybody's just thanking you for staying up late for us. And we learned something here in our webinar. We have to probably practice pronouncing names like yours. So we don't want to butcher names anymore. So that's our assignment, Dr. Bill.
Okay.
Thank you again. Thank you.
I did the best I could. I actually practiced a little bit, and that's what came out.
that's already good practice. See, we have to work on that.
Yeah. So Anybody else have any comments or questions? I actually have a little bit of a story about that. My son, those of you who don't know, is married to an Asian woman, and we went to the wedding in northeast China, and her grandmother was being a little bit ornery, and she didn't speak English. In fact, the grandmother was Korean, and she was sitting at the table, just about kind of ignoring us and turning over playing cards, or they had pictures on them, and she would turn the cards over and start and say what it was in Korean. And I was standing there watching her because you all know who I am. I have to be everybody's buddy. And she's pointed to it and said it what it was in Korean, and she turned over a card that was a flower. So she said what it was in Korean, and I tried to say it. I tried to say what she said, and you remember this is a very stoic, serious. She must have been in her 80s, and she nearly hit the floor laughing. And we carried this on for about 2.5 hours, and I was told that nobody talks to grandma like that. Grandma ignores everybody. And then I had her trying to speak English, and it sounded as her English sounded as ridiculous as my Korean did. I'm sure of it. So I did try. I did try to practice your name. I think I got the first name down pretty well. And we really want to thank you for staying up late for this presentation. Like I said, this is a little bit different than what we're used to, but it was really fascinating, really, really interesting. And I'm glad Dr. Halas and Dr. Joseph were around, sort of to bring us a real life case with it also. So, and of course, then the question is, okay, when's your stuff going to be out so we can use it?
I know.
Yeah.
We want to have we have the same goal. We want to do the same.
We'll give you to March 1st. Okay.
Okay. Okay, I have a month.
Any summary, last thoughts, anything like that?
We have now an excuse to travel to France to meet with those doctors, right?
Yeah. Mm-hmm.
You can always come to Nice. Well, I'm in Paris, where it's north and cold, but
I do travel a lot. I travel a lot to Europe, especially Germany. So at least now I have a reason to go to France.
There you go.
You should go. Yeah, you should definitely visit the laboratory that I did my PhD in, and meet the team leaders, Dr. Corinne Bertolotto and Dr. Robert Balotti. I will write you all these names, and the medical doctor that he's also treating the patients of uveal melanoma, and Dr. Thomas Trup, that he was also a colleague researcher helping me. They're all brilliant people dedicated to fight melanomas. Actually, the laboratory name is from skin pigmentation to melanoma pathologies. And yeah, they're very helpful. So yeah, come for the sun,
Yeah,
for
I
the
will
sea,
come and see if
and
we
for
can
the science.
come up with some collaboration in terms of clinics in the United States and France, looking for also funding, investor, all these things. We can talk about it. Possibly me and Dr. Joseph will travel to Europe and meet with your people and see if there's anything that we can collaborate, or any platform of collaboration that we can do, whether even education, conference, CME, things like that. There's many levels of collaborations that we can talk about.
I'll bet you can't.
Excellent. That sounds great.
You can't say that. I bet you can't say the name of the clinic in French. We want to hear the name of the clinic you just mentioned.
What's the name of the clinic?
Yeah.
You mean
what's the name of your center?
Okay.
Where you did your...
Wait, because I need to remember it also. It's like a huge name that I never pronounce. Okay, Centre Méditerranée de Médecine Moléculaire.
Mm-hmm.
Wow.
Yeah. Okay.
That's a story
works
by
for
itself.
everyone. C3M.
All right, everybody. We now know she's way smarter than any of us. That's for sure.
No.
Can you pronounce that? Can you spell that, Dr. William?
No. I'm not even gonna try.
À l'hôpital Necker, c'est Monsieur Benson, c'est où? He did a training in hospital Necker. I have no idea where it is. Is it in Paris or Hôpital Necker? How do you have such a large percentage of French-speaking people there? Ah, Paris. Yes, Hôpital Necker. Okay, I'm Paris.
We have Dr.
Okay.
Benoit. Benoit is a French speaker.
Dr. Ben, yeah, Dr. Tano,
Reno is a French speaker, so we can have him translation for us.
Before we started, the two of them were talking in French, behind our back. I felt like my other thing is that my children, when I was young, when I was a young boy, my parents and my grandparents would speak in either Russian or Yiddish when they didn't want us to know what they were saying. And then I grew up, and then now my children do that. Now my son and his wife speak in Korean or Mandarin, and then my daughter and her husband they're fluent in Swahili, as are my 4 grandchildren. The oldest one, age 9. So when they don't want me to know what they're talking about, they go at it. So it's.
In the beginning it was just to have a warm get to know each other.
But you don't have a heavy English accent, like French are the French when they speak English, they have the unique accent there. You don't have that. That's a good thing about you.
I'm not French. But my mom told me, because she's an English teacher and a poet, she told me that throughout the years, I developed in some words a little bit of a French twist.
But there's not that
oh
hard.
My God.
That's not dark. It's not that deep French. So I don't see that you're originally from France. That's I can see. So where are you from originally?
I'm from Greece.
Oh, from Greece. So, and RGCC are from Greece too. Possibly that's a good collaboration. Possibly this will help to sponsor your lab. I will get you something about that. I think most of those academies, they're looking for a company to sponsor them. And I will see and talk to RGCC.
I will get you her contact, Dr. Halassa. Don't worry.
Yeah, that's what I'm trying to do.
Okay. All right. Well, Dr. Evangelica has been absolutely fabulous. And you are hands-on, the smartest person we've ever had in the last years.
I'm just in a different field. Thank you very much for having me, and it was a pleasure to discuss. And it's actually very insightful, also for us to be outside of research community and speak with medical doctors, because indeed you ask different things and you search for different things that you have to remind us, because it's more of the side of the clinic. So
one last question. What is your next steps?
I don't know. Currently, I'm looking for a job in Paris. We will see if I will have, I'm open to an opportunity maybe for a postdoc, or in a private company in an R&D, because like I said to the last slides of entrepreneurship, but this falls under the general category of developing therapies. It's an expensive hobby. Let's say that is a hobby. It's an expensive hobby. So you need to be in a professional family that you have money. And so either big companies or startups, or we will see.
Great. Thank you.
We will keep you informed, Dr. Tano. So
yes, thank you.
We will let you know when the big breakthrough comes, and
right.
She's the Nobel Prize winner of 2028.
Oh, no,
exactly. Yes.
Okay.
Need to put your dissertation for competition. Maybe you win something. You never know.
We're putting you up for the Nobel Prize next year, by the way. So. Okay, because you were the smartest one on here now, but now I think she's surpassed you a little bit. So.
Yeah, she's the one. I'm just at the bottom here.
Okay. All right.
Oh, thank you for the conversation.
Thank you for a great presentation. Next week, by the way, we have Allison Beasley on, Dr. Allison Beasley, and she does everything with light therapy, particularly ultraviolet red and ultraviolet blue. So we're going to learn about light therapy next week. Okay.
Awesome.
So
Nice.
that's that. There's one last comment. Please look at AMPK, SIK2, and vitamin D relationship.
Vitamin D relationship.
Okay. So we're going to have you report back to us. So we always say if we don't like you, we don't bother you anymore. So those are
No, please. No, these are very helpful tips and publications that maybe I did not see. That doesn't mean that I know everything and I've seen everything.
well, we'll give you another couple of weeks, then you'll know everything, right? Anybody else have any last comments, questions? Again, thank you so much. We really appreciate this. We really appreciate you being up in the middle of the night for us. And we really can't thank you enough. I'll have the recorded video for you when it's ready. I'll send it to you. We also, if you want, we can send you the contact list of everybody that was on here. It's something that we do. 2 AMA CME credits. It's in the chat. It's on the email. It'll be added to the email that we do every week. They're all there. This will be CME credit hour number. This is number 25. They're $30 for 2 credits. So that's $650. You can get 50 credits, which is way better than any conference that you'll get. So if you need CME credits, go there. And I sent out a separate email over the weekend also with just the links for the videos that we have accredited. So we marshal on. We're gonna start getting together with Dr. Fong to see if we can get a live conference this summer in Vegas. I know it's hot and kind of miserable that time of year, but it's a tradition for them, and it would be easy for us to hook on and have sort of a somewhat ready-made audience. So we're gonna start that process. Anybody that wants to present anything or be part of it, please let me know. Dr. Halasa, has access to AMA CME credits, and then the Nevada Osteopathic Medical Association has the DO credits. So we got both covered. And one last thing, Dr. Nario, what's new in the alternative medicine world that you're studying now that you've been there a month?
Well, it's all about, I guess, debulking what I know. They're just saying that our allopathic ways of talking to our patients are not going to be the trend of the newer generation of integrated medicine practitioners. So I'm learning a lot about motivational interviewing. Mm-hmm. So it's all about being more of an assisting guide to your patient rather than directing them towards what you want them to do. Mm-hmm. It's all about these techniques. They're refining our skills and trying to break us down.
So what you're telling me is that I graduated from medical school in 1978. I had 4 years of internship, residencies, a couple of years of fellowship, almost 45 years of clinical practice doing histories and physicals, and you're telling me I've done it all wrong all that time. Is that the take-home message?
They're telling me I'm doing it all wrong. I don't know if that's going to be applying to you, because they're breaking me down from inside out and just saying, hey, you need to tweak this and do this, do that. Well, hey, I'm pretty open.
I know, you've been in my office for for many sessions, and I've told you you've been doing it wrong all along too, but you didn't.
Yeah, I'm just stubborn.
Yeah, you had to go to
the university to tell me that.
You have to go to the university to tell you. Okay, Dr. Evangelica's email is there. Her LinkedIn is also there in the chat. And there's an au revoir from her. Thank you so much. Really, we really appreciate it. I don't know what else. I'm overwhelmed with awe.
Thank you for inviting me. And anyone, feel free to contact me whenever you want.
Anybody have any comments or questions? Anything anything out there in the real world we need to know about? Anybody going to any conferences? Anybody presenting at any conferences? And that we need to know about? Any new tips or tricks that we think the group should know about? Going once, going twice. Okay, Evangelica, thank you so much. Go get some sleep.
I will.
Okay. Are you working?
Have a nice afternoon, evening, I don't know, everyone. And thank you very much.
Evening.
Yeah, it's almost 7 p.m. here. So
okay.
Okay.
Have a nice evening and yeah.
Okay. And again, like
ciao, everyone.
Good night. Like I said, next week, Dr. Allison Beardsley, we're going to be learning about ultralight therapy. I know a lot of you, know quite a bit about it, but some of us, are like I'm dating myself, learned nothing about it. So I hope that'll be somewhat interesting. Do you have anybody that would like to present, or if you would like to present, please let me know. We're booking out until the April and May already. So if you have any topics that you want, let me know, and we'll see if we can put them together. Okay. Any last word, Dr. Naria?
No, keep on going. This is good stuff that we have. We're getting international coverage now, if you notice. So we're getting our arms all stretched out, and hopefully we're gonna get some more of those.
Speaking of which, on Friday, I signed up for a integrative medicine conference online in London, and so we've introduced ourselves to them, in our group. So I think we're going to be able to find some new members in the UK. So
good.
So keep on spreading the good word, and we'll keep fighting on this end. Okay. So good night, everybody. Have a great night. Any last words, Dr. Quinn, on the anything else we need to know about the what the research people are up to?
No, not really. I think we covered it ahead of time. If people want to participate or listen or hear what we're doing, they're more than welcome.
Okay. All right. If you get forward, can I put the link that you do on Saturday morning on the web on email, or is that?
Yeah, it's Dr. Tano's link.
Okay.
I don't know if he's still on.
His name's on.
What? I didn't hear the question.
Can we
the link for Saturday?
Link?
Oh yeah, I can. You want me to send it to you or send it to?
Send it to me when you get a chance, Dr. Tano.
I would do that. I will send it to you. So if you want to invite other people, you can.
Okay. All right. If as long as it's okay with you guys,
Dr. Nario, we tried to invite you several times, but it looks like your email we have is not working.
I'll send you guys my email.
Oh, I thought he didn't like us. Oh, is that what it is?
He doesn't, but he's too polite to say.
Oh.
Well, I work on Saturdays. That's why I kind of just chime in and listen to you guys in between patients.
Right.
But I'm a big fan. You guys are moving mountains, and I'm also a member of the Tribal Healers. So I'm a big cheerleader. So I'm already part of that group.
Excellent.
See, I'm not showing up, but I'm signing behind the scenes.
Okay, that counts.
What group are you a part of?
The Tribal Healing Turtle. Okay. Remember Dr. Dan?
Oh yeah. Oh, you signed up?
Yeah. Mm-hmm.
Yeah. Dr. Dimitri did as well. He's very proud and very happy. He wanted to make sure he got in before we came up with some strict guidelines, I think.
So rules that would leave us out. In other words, right?
It's like a flash sale for our Black Friday. You have to hurry up before the sale ends.
First come, first serve.
Yeah.
It's like you don't want to be part of any group that would have us as members.
That's hilarious.
All right, everybody. Have a great night, and I'll get everything that we do together, and we'll see you again next week. Okay, and Saturday.
Thank you.
Okay.
Thank you. That was good.
Thank you.